Welcome to the Fatal Facts of Fentanyl. This is dedicated to raising awareness of the illicit fentanyl crisis hitting the USA. It is killing tens of thousands of people who suffer from substance abuse, disorders, and first-time users. There are no boundaries. It is straight across the board with a number of deaths without any regard to race, sex, socioeconomics, age, education, religious background, or location. It is in every community within our country. The fentanyl crisis is deadlier than ever before for various reasons. It is time to address the many issues surrounding this crisis. It is time to listen and learn from experts. It is time to hear the many stories from people who have lost their loved ones due to death by deception. Change begins with each of us as individuals and collaboration with others towards this positive transformation. The goal is to save lives and families from this travesty. Awareness and education are the key. Knowledge is power. I am your host, Lisa Carol Cood, an educator and advocate to help bring awareness to the fentanyl crisis touching every facet of our society. I am a mother who recently lost her son to fentanyl poisoning. I know firsthand the pain of grief surrounding the loss of my firstborn son. I created this podcast in hopes of channeling my heartbreak and put my energy into trying to prevent similar tragedies. I find solace and strength in working to spare other families a similar grief and any person battling this addiction. Tragedy has a way of being something powerful. This is in honor of my beautiful son's life, forever 32. Right here on Fatal Facts of Fentanyl, you will learn from experts on the front line combating the many issues surrounding fentanyl. You will hear personal stories from families and friends who have lost their loved ones and have taken their grief and pain to turn it around to make positive changes and bring awareness and education. You will also listen to people who have struggled with an opioid addiction and are still struggling and are now in active recovery. All of us share a common bond. We are all here to make a difference. We are all here to bring you the fatal facts of fentanyl. Understanding addiction. No science, which is KNOW, and no stigma, which is NO. Let's end stigma surrounding addiction in this country. Stigma is our biggest killer. I have today as my guest Dr. Charles Smith. He and his colleague, Dr. Jason Hunt, are the authors of their book, Understanding Addiction, No Science, No Stigma. They bring a unique and important perspective to the subject of addiction. An expert in this field, Dr. Smith has a personal, first-hand experience with the shame and humiliation that accompanies substance use disorder. Addiction is a disease, no less so than diabetes or heart disease, and it needs to be treated as such. Hi, Charles. Welcome. I hope you don't mind me calling you Charles. But first, let's clarify that statement for our audience. Addiction is a disease. Tell me what you know about that, and let's begin with the science behind that statement.
Well, my interest in that particular phrase happened when I went to treatment myself in 2009. I had been a family practice physician in West Virginia and Kentucky for 26 years. And in 2009, due to a series of interventions that I describe in the book. I went to treatment myself. But when I got there and spoke with the addiction medicine physician and the counselors and the therapists, they told me, "You have a disease." And I said, "What? Wait a minute. I drank too much, okay? And, I got hooked on those pills, but that could happen to anyone because I had a sample cabinet full of them." And that was my knowledge and my mindset at that point. And of course, that was almost 13 years ago now. Since then, I have learned that it is a disease, just like diabetes, just like heart disease, just like hypertension. And it can be identified through a particular area of the brain and a particular system of the brain, the dopamine reward system and the dopamine reward system's effect on the prefrontal cortex and our decision making. And that's really what prompted me to write the book. I check in patients at the two detoxes that I work here in South Florida daily, and I go over this with them that certainly they did have some bad behaviors, but I think those bad behaviors can be explained due to the fact that they had a vulnerable dopamine reward system.
I read your book, by the way. Thank you. And I actually learned a lot from it. I wish I knew then what I know now that I've learned more about addiction. Can you explain to our audience about what you mean about the dopamine receptors? Because a lot of us, parents or people who have a loved one who has an addiction, especially an opioid addiction, we can never understand, why can't they just stop? Explain that to us. I mean, I found it very interesting about that part of the brain.
Well, I always start out by using that little example, the newborn infant. You have a newborn infant in the nursery, goes through the trauma of childbirth. Then, a couple of hours, he's going to be laying under the incubator and he's going to start crying. So I always poll my audience, why does this baby start crying? And people will say all sorts of things. He's cold, he's wet, the lights are too bright, he misses his mother. But the bottom line answer is he's hungry. So his dopamine reward system signals him that there's stress and trauma, and if he doesn't get some carbohydrates, he's going to die, which is the fact. So when that infant gets carbohydrates, his dopamine reaches up to near top, what I call top normal levels. It goes up to almost 200 in the midbrain. When that happens, the infant's calm and serene, his restless, irritable discontent goes away, and he's comfortable. That system continues to operate on through life, with dopamine being released for eating when you're hungry, drinking fluids when you're thirsty, escaping danger, even sex gives normal dopamine releases, which start to modify our behaviors. So, because we have that inherent desire to sustain life. Then enters mind altering substances, and that's anything that releases dopamine higher than 200. Alcohol, opiates, benzodiazepines, cannabis, amphetamines. And when those are released at that much higher level, it's a little bit like noise exposure hearing loss. If you go to a rock concert, what can you hear the next day? Not very much, just ringing in your ears. So those massive releases of dopamine are what dysregulate the system. And of particular importance here is that about 9 out of 10 people cannot accept those massive releases of dopamine. The 1 in 10 people in the general population that can have a vulnerable dopamine reward system, and they're the ones that are very much at risk for the disease of addiction.
I find it so fascinating because we all know people that can drink or do pills or whatever, and it doesn't affect them. They can easily walk away from it. And then we also have people that can drink or do pills and they become highly addicted to them. So I guess, are you saying that some people's dopamine levels, that's what happens to the brain, why they just can't stop that population that I'm describing? That actually that you had, that exactly. Is that right?
Yes, that's exactly what I had. I had many of the risk factors that set me up to be able to accept that reward when that large reward's released. And primarily that's due to dopamine subtype receptors. But there are also other factors involved as far as amounts of dopamine released, the ability to accept that dopamine. It isn't quite as simple as that I could simply accept the reward. There's many other social factors involved, but the bottom line, I use this as an example with patients many times of what I call an addiction stress test. And if I go up to anyone at a restaurant, maybe they're having a margarita, and I say, well, you know what? It's your lucky day. You get 5 more margaritas on the house. 9 out of 10 people will decline those. And when you ask them why, they're going to say very simply, I don't like the way 5 make me feel. None of us at risk for the disease of addiction are going to say that. Now, we may decline that extra 5 if we still have the ability to make good decisions. Maybe we know we're driving, maybe we know we have to work the next day. But for the most part, we want them. So that's my stress test for addiction. Now, it may not be that alcohol is the drug of choice. Maybe it was opiates, maybe it's cannabis, maybe it's cocaine, maybe it's amphetamine. But the bottom line is 9 out of 10 people simply don't enjoy or are able to receive that reward from those massive amounts of dopamine.
That makes sense when you explained it. What are some of the risk factors?
Well, the risk factors, the number one is the genetic predisposition. If you have a first or second order relative who has had problems with alcohol or drugs or has the disease of addiction, you have at least a 50% chance of having that yourself simply by being exposed to those substances. And that makes it very rare that you wouldn't be exposed. I mean, it's somewhere around 87% of the people in the United States are exposed to alcohol at some point in their life. There are a few religious subsets that don't drink, and some very health conscious people just never drink alcohol, but that's very unusual. So, genetic predisposition is one. Age of early youth is another. Many of the patients I admit started their substance use 9, 10, 11, very, very young. This dopamine reward system doesn't mature till ages 24 or 25. So it's a very vulnerable time to have that massive release of dopamine. Another is adverse childhood experiences, someone who's experienced abuse, trauma, physical, emotional, sexual as a child, also makes them very predisposed to this. High tolerance to substance. If you're one of the teenagers who could drink 12, 16 cans of beer or a whole bottle of wine, it simply exposes you to more chemical and more milligrams of the substance. Another would be dual diagnosis. Patients who have anxiety, depression, bipolar disorder, even schizoaffective disorder. All these also give you much higher risk of having a vulnerable dopamine reward system.
Yes, sir. And for what I read in your book, it's not like a person has to have all of these risk factors. They can have simply one of them, right?
Yes.
And
Yes.
is that true?
Yes, that's true. And, also when patients tell me, I don't have any family members, I always say, well, when I look at your DNA simply by your known family history, That's a little bit like asking you what a Harrison Ford movie is about simply by showing a snapshot of him. You wouldn't know if it's Star Wars, Indiana Jones, or what the movie was about. So I'm still a big proponent of the genetic predisposition being the main risk factor.
Yes, I agree on that. And it's just like when you go to the doctor and they go, well, what's your history of diabetes or cancer or heart disease in your family? It's like they don't ask you about addiction, but they ask you about like what you're predisposed to. And it makes perfect sense if we're going to treat addiction as a disease because um it can be like a grandparent. It can be uncles. It can be like somewhere down your, generational lineage, so to speak. It doesn't necessarily have to be first generation. We can all go back somewhere down the bloodline. Is that correct in saying that?
Yeah, yes, it is, and it's interesting that you say that physicians don't take that history. There's many reasons they don't. One may have to be that maybe they don't have the training to ask the question. The other is maybe it's uncomfortable for them to ask the question. But University of Florida, where I did my addiction medicine fellowship, was the first university to require a mandatory rotation for medical students in addiction. So during my 2 years there, we rotated one or two medical students through each month and reinforced to them the reason they should ask the family history pertinent to addiction.
That's awesome because I'm sure, university, doctor, medical schools in the past did not train doctors about addiction. And as prevalent as it is in our society now, I'm sure there's a bigger and greater need for that now. So are you saying that they're starting to do that, implement that into training for our doctors
Yes,
and medical personnel?
as far as I know now, all medical schools do include addiction. It's very much to the forefront in continuing education. The whole prescribing of opioids has been revamped in the last few years so that physicians take that history of that we just talked about, family history of addiction, and also that they monitor more closely the supply of opiates they give. For example, say 30 years ago, you had your gallbladder out, you may have got sent home with 30 Percocets. Today, when you have laparoscopic gallbladder surgery, you get sent home with say five milligram oxycodone. And if you have more pain or require more, it's going to involve another physician interaction to get more. So those those cabinets all through the country at home that may have 25 or 30 Percocets in them simply not there anymore due to the physicians being educated and simply not overprescribing.
Right. It's more regulated. Is that correct in
Yes,
saying that?
yes, it is.
Um, Dr. Charles, I'm going to ask you some personal questions, or I probably don't even have to ask you, but I find your history very, very interesting. And I read your book and I learned so much about yourself and your colleague. But do you mind telling our audience um, about your history and what happened?
No, I don't mind at all. Uh, I was born in West Virginia, went to medical school at West Virginia School of Osteopathic Medicine, and had a pretty inconsequential college career and medical school career. One thing was very important. My grandfather on my father's side died of the town drunk in this very small town that I was raised in southern West Virginia, 5,000 people. I only met the man twice, and my mother would simply say, "That's your dad's dad, and he's a bad man. He's an alcoholic." So I only met the man twice, and he died a street alcoholic and was never able to obtain treatment. So even with binge drinking in college, it didn't continue for me until my early 30s when I was faced with a lot of stress. I had work stress. I had financial stress, I had marital stress, and I already knew that I could drink pretty pretty good lot. I had a high tolerance, and my drinking picked up to the point that by my mid 30s, I was coming into work with alcohol poisoning, just so sick I couldn't put one foot in front of the other. And that was late 80s, and about the time Vicodin and Lortab and Xanax were being sampled to primary care physicians. So I went to my sample cabinet, looked at it, and said, I wonder if a few of these would help. And after that, the next 20 years is somewhat of a blur. I got my pills many different mechanisms, from ordering them wholesale to finally writing fraudulent prescriptions, which in 2009 resulted in my intervention by the DEA and got me to treatment and subsequently saved my life.
Wow. Well, the movie, the series Dope Sick is very popular now. And it kind of is describing a little bit what your experience was, just like Michael Keaton, the doctor in Dope Sick went through with his addiction. He was prescribing it for his patients. And then apparently he had a, I don't know, he started on it because of pain. And it was that's how easy, what you just described about yourself, that's how easy and innocent it can start. Is that correct in saying? It's like no one is born, or no one, I believe, says, okay, I'm going to be an addict when I grow up, or I'm going to be an alcoholic, or I'm going to do this and that. And then it just starts innocently. And it just continues in this downward spiral. Is that how you felt at times?
Yes, you're exactly right. In second grade on career day, no one holds their hands up and says, I want to be an alcoholic or I want to be an opiate addict. So you're exactly right. But once that door was open and my alcohol consumption increased, it was really just a path of least resistance of what I could do to stay functional and what I could do to survive. So I don't want to make it sound like I didn't have a choice. It was just that ease of access I had to those pills made it the easiest route of choice for me.
Right. Which happens, with a lot of people that I've interviewed, and people that I've known that to have some sort of substance use disorder. I call it substance use disorder. Let's talk about that. How can we as a society break the stigma of this so people do not feel ashamed or guilty? And there's a thin line holding someone accountable for the behavior of the addiction. But I feel like to understand the addiction, like you said, like the science behind it, it will give people or our society a little bit more compassion and not judge people so harshly. But yet some of the behavior that is displayed, I feel like people need to be accountable. Do you kind of see where I'm going with this? It's kind of like a catch-22 situation. How do you feel about some of those statements I just made? How can we end the stigma first?
Well, I think by sticking with current and even more progressive scientific literature is exactly the way to go. It would be real easy to put out stigma related statements for diabetes, for overweight, for lung disease, because many diseases, patients play a part in that disease coming along by their behaviors. So with addiction, the words alcoholic, the word alcohol, addict, junkie, abuser tend to have a negative connotation. Words are hurtful. It's much better when we describe them for just what they are: substance use disorder, uh, habitual use, overtaking of substances. I mean, if it's done thoroughly yet compassionately is the best word. I was thinking one of the things is whenever we go to do interventions, or whether I see a patient with intervention, I don't look at this any different than if I saw a skin cancer or a suspicious skin cancer on your face. I approach it with that same vigor and intensity. So if I see a person, or the family has done the screening tools that we can talk about, and they have it, I tell them not to give up any more than they would if they said, "Oh, I think that's a malignant melanoma on his shoulder." Well, you wouldn't just sweep it under the rug and say, "No, maybe it's a freckle." You would get professional evaluation. So this is no different. We really advocate that people get professional evaluation. Then maybe it turns out that they are just a light social drinker and it was all a big hubbub. But that's not very likely, or the family wouldn't have noticed the changes.
Right. What do you do when you want to call in an interventionist and you want to call in an addiction specialist? This is for someone that you love very, very much. And you see the person struggling and you see the daily fight, like moment to moment with an addiction. And I'm talking now an opioid addiction, which I think is so strongly, highly potent, whether they're prescription or illicit drugs. But how can you encourage and love that person through this um, without enabling them? And then also, how can you lead a horse to water if they don't want to drink, so to speak?
Well, and I understand exactly what you're saying. In my years out of medicine, I did get trained in interventions and did professional interventions for a few years. It is difficult. Once again, I take them back to that same medical scenario. If you had a patient who you were suspicious, say you had a sister who had a breast lump, you're suspicious of breast cancer, but she just simply says, "Well, I'm not going." You wouldn't give up on her. That's what you have to do with, say, the opioid addicted patient. You can't give up on them. Where most families would fail is that ultimately it may mean loving detachment, or used to be called tough love. But you said, how do you do it without supporting him? You may have to say, well, if you choose, for example, to keep this cancer and not seek medical care, then we're going to have a break in our relationship. And most people have difficulty with that. Obviously, they love them. One of the definitions of codependency is love, because it's the root of it.
Yeah, there's a thin line between codependency and interdependency in all relationships, actually. And you do have to love and encourage them through it and not be judgmental. But then ultimately, it seems that it's up to the person to take that step and seek medical detox, because I feel that's what's needed, and I'm sure you feel that's what's needed, and rehab and long-term treatment centers. And let's talk about that. How long does it take if a person who goes through all those steps as far as to get out of active addiction into active recovery, how long does it take for the brain to heal if they follow all those steps? Is there a number of years attached to that, or is there like variables in there?
Well, there are some variables, but you can find very consistent that it's 1 to 2 years before this dopamine reward system is going to heal, and primarily the prefrontal cortex, or the decision making portion of our brain. 1 to 2 years. So, that old Minnesota model of 30 days rehab is basically archaic. If you just go for 30 days and you go home and you expect to be recovered, that would be no different than putting a cast on a broken leg for 2 weeks and say, you know what, we're going to take this off. And you go, well, that won't work, doctor, because it's going to take the bone 6 to 8 weeks to heal. This is the same thing. We need that sort of intensive treatment for addiction for 1 to 2 years. Now, that doesn't mean we keep them out of their home. But once they do return to their home, we still have cognitive behavioral therapy, 12-step mutual aid, and possibly the most important factor here is we have random testing so that we keep mind altering substances out of the body. And that's the biggest failure we see with lay people treatment in the United States. We've figured that out when it comes to doctors, nurses, and airline pilots because that's the type programs that we're put in, and we have 90% success rate. But for the general public, that's simply not in place yet.
Do you feel like I know through the years that that I watched my loved one, I feel like each year it's getting better and better. There's more education about this. There's more awareness about this. The programs are getting better. I still think there's a major big need in this country, but do you have hope about this? I know you work in a treatment center yourself and medical detox with your patients. Do you see a growing awareness of this in our country, that people are starting to open up and there's more avenues for people and their families to seek this? Do you see that, or am I naive about it?
No,
And
no, I actually do see it, and to tell you the truth, it mirrors almost any other disease that we've seen progression in. Since I graduated medical school in 1982, that was right at the beginning of the HIV/AIDS crisis. So I saw all the stigma associated with that. Then basically the opening up of that to get more funding for research made it a more mainstream disease. And ultimately, we're at where we are today, which there's excellent treatment, and it doesn't shorten lives today. That same type vigor and enthusiasm is starting in addiction. It's not there yet, but as you said, there's many avenues now that are pursuing more intense education, early education, and also advocacy for treatment. It's more understood by most major companies now that this is a disease and that once properly treated, they can have a better employee than they had before.
yes, sir. As far as recovery treatment, what do you feel like the components are, the important components for someone to have a high success rate? Because from what I understand, and correct me if I'm wrong, there's a very high incidence of relapse and during recovery, during active recovery. So with your experience, what are the components that someone has to follow through with in order to have that high success rate? And is this something that they live with every day of their life? That like you said, a lot of people, I think, falsely leave treatment centers or recovery centers and think, oh, I'm cured. Everything's going to be fine. I can go back to that lifestyle, or I can be doing this. And I have found personally in my loved one's life that wasn't the case. So can you kind of elaborate on that for my audience, please?
Yes, and the perfect analogy that I use with patients is the treatment of high blood pressure, treatment of hypertension. I did family medicine for 26 years. It was not unusual at all for me to see a patient, diagnose them with hypertension, start the medication, ask them to come back in a month and see them. They came back in a month, pressure's good. I say, okay, any questions? Here's your 6 months refills on your medication. Come back and see me in 6 months. Patient comes back in 6 months, blood pressure sky high. I go, what happened? He goes, I just didn't think I needed that. Addiction is actually no different. It's very important that initially they get a good professional evaluation so that they can see what level of care they go in. Maybe they don't need detox. Maybe they don't have enough comorbidities to require residential treatment. Maybe they don't need sober living. But the big thing is they've got to have treatment for 2 years. We've got to keep mind altering substances out of them. And that's the advantage to monitoring. When you're monitoring, one slip, even if it's not their drug of choice, maybe they were opiate addicted and they smoked cannabis, maybe they were methamphetamine, they drank some beer. We still need to know it because then we can intervene at a much less intense level of care. So
That
I
makes sense.
always, with patients, parallel it to hypertension because hypertension still in the United States today is very difficult to treat because it requires so much patient compliance. That's what addiction treatment requires, patient compliance. But, most of the time with this 30-day model of treatment and then send you to your local AA group is not enough accountability.
No, I agree with that. Um, that's why I highly recommend your book so people can understand the science behind this. I assume, do you consider this a brain disease?
Oh, absolutely. No different than the dopamine reward system is dysregulated, no different than the glucose insulin system and diabetes, the renin angiotensin system and hypertension. This is a bodily system that becomes dysregulated, results in a disease. However, with appropriate treatment and management, the disease can go into remission. Now, I never want patients to get confused. Remission, does that mean I can go over here and drink some beer now? No, it doesn't. It means my brain's healed enough now that I'm actually make good decisions and know that I'm one of the 1 in 10 people in the world. It's not a good idea to drink and drug. Yet, I did it for 30 years because I was making poor decisions because of my brain disease.
Well, I don't think there's anyone on this planet that has not made a bad decision in their life. Um,
There is
but
there is something there though. In chapter 4 of the book, we talk about the decision making portion of the brain, the prefrontal cortex, and how we have low oxygenated hemoglobin in that portion of the brain in active addiction. It's impossible to make good decisions.
it is impossible. And I'm going to throw something else at you since you brought that up. Um, I think this is one thing that needs to change in this country. Say, for instance, and this happened firsthand with my son, he overdosed. I'm going to use the word overdosed. And he was taken to first he was shot with 4 or 5 shots of Narcan, brought him back to life. The sheriff told me that. Taken to an emergency room. I'm thinking, oh my goodness. Okay, he's in the hospital now. They're going to take care of him. They're going to know that he has a highly addictive, he's highly addicted to these opioids and heroin at the time and whatever else. And so they left the decision up to him. They left this hardcore decision up to him. They did not offer him treatment. They just talked to him, where me as a mother thought, oh my goodness, they're going to do something now, or they're going to help him or offer something. But they left this hard decision up to him, and he walked out of that emergency room. He refused any sort of help and treatment. So I know that's because of the HIPAA laws, but is that something that you feel needs to be changed in this country? Because the loved ones have their hands tied. And they're leaving this important decision up to somebody who isn't capable of making this decision to save their life. Do you understand what I'm trying to
Yeah,
convey?
yes, I do. And most states have some sort of legal alternatives to follow here. In Florida, it's called the Marchman Act. Other states, it may be called something else. But anyway, it's a substance use disorder involuntary treatment. Now, it results to start with in just an involuntary evaluation. But see, that would be the start of the treatment anyway. So I always told families, should I pursue that? And I said, of course you should. I still remember one intervention I did back in Alabama. A gentleman was drinking. His sisters actually called me in to do the intervention, and he was drinking significantly. He had alcoholic cardiomyopathy. so severe drinking, and his life really depended on it. He refused. He refused to go. After the family intervention, after the letters, after all the loving pleading, he still told them no. They asked me what our next step is. And I said, you need to call law enforcement. He just left here to drive home and he's intoxicated. And they said, oh no, we can't do that. He'll never speak to us again. I told them, pretty soon he's not going to speak to you again anyway.
Well, I want to let you know something. I was going to do that. And I was going to go to the county, the sheriff's department, and I spoke to them, and they told me about what needed to be done. They had to go arrest my son and then take him to the hospital and talk to a psychiatrist, an interventionist, a medical doctor, be evaluated, and they would hold him for 72 hours. But then I was told if he could still walk after 72 hours. So actually, when I spoke to the sheriff's department here locally, they kind of talked me out of doing that, to be quite honest with you, because they said, well, they're going to let him go anyway. So do you understand what I'm saying? That's what happened in my state. I don't know if they've changed it in the last 4 years, but that's what happened.
It needs perfected in every state. But even 3 years ago, in the 2 years I spent at the University of Florida, we marched and enacted many patients and kept them for 90 days. The judge had that ability once we showed evidence. Now, patients can have a show cause hearing and go up in front of the judge where both sides present their cases. But we kept many patients for 90 days, which in itself still wasn't still enough, but it was sure better than the 72 hours you're talking about.
Yes, sir. And yes.
And I know what you're saying, have him arrested, go through that trauma, go through that embarrassment of being involuntary committed. It does seem like a horrible thing. I understand that. But when we're talking about a deadly illness, it's necessary. And
well, I would have done it in a heartbeat if I knew that they would have kept him. And they still left the decision up to him to walk. You know what I mean?
But see, that's the true involuntary commitment for substance use disorder. It's the decision to leave not left up to the patient. It's left up to the addiction professionals.
Well, I hope they've changed that here in the state that I live in, because like I said, this was 4 years ago, and yes, sir, I knew all about it. I was ready to do it, and they talked me out of not doing it because they said that he would walk. They couldn't keep him. They couldn't keep him against his will. That was what was told to me. But anyway, let me ask you something. You know, my podcast deals with the fatal facts of fentanyl. So in your experience as a doctor, tell me what you feel about illicit fentanyl. Are you seeing a rise in this? Has illicit fentanyl been around? From what I understand, it's been around at least 4 years, and people are highly addicted to it. Tell me your experience about illicit fentanyl and how you think about this, or what you think about it.
It certainly was a game changer. For at least the last couple of years, most of my opiate patients that I've admitted to detox or to residential rehab did not even know that it was fentanyl they were getting. They were buying these pressed pills that they thought were oxycodone 30s, or they thought they were Xanax bars. They did not even know they were fentanyl. The degree of strength of that fentanyl just varies on how much it was cut. You know, it may be thousands of times stronger than morphine or heroin, or it may not be. There's no quality control among the illicit drug world. With the massive escalation in overdose deaths that we've had, 93,000 in the U.S., and that's a low number because many died that we don't know why, and it probably was opiate overdose. We're starting to get some more attention to these illicit pills. The DEA sent out several emails and newsletters focused on these pressed pills, as they call them, that they look like the prescription pills, but they're not. They're fentanyl. So the fentanyl entering the market has been a game changer. And we certainly saw a lot of overdose deaths with OxyContin, with oxycodone, and Xanax, and then mixtures with alcohol also, but nothing like we're seeing now.
Yes, sir. It seems like the illicit fentanyl has changed the paradigm of drug use in this country. Um, the way I look at it, and I've talked to several experts about this, and also people who have lost loved ones to this. It seems like there are three kind of scenarios for this, and you can correct me if I'm wrong or add another scenario if you know of one. But it seems like we've got the seasoned, I call them the seasoned users, the people that do knowingly know that they are buying fentanyl, and they are ingesting fentanyl. And there's different ways to ingest it, of course. And then you've got the people, like you said, that feel like maybe they're buying an Oxycontin, I guess Roxy's, is that what they're called? M30s, whatever. Is that what they're called?
Yeah, yeah.
30. Okay, there's so many terminologies, but or they might be thinking they're buying cocaine or buying a Xanax or heroin even though I've read and heard that heroin's the most obsolete now because of the fentanyl. But anyway, they kind of are deceived. All of a sudden, they're dying from ingesting straight fentanyl instead of like thinking they're doing a line of cocaine. And then you've got, like you said, the press counterfeit pills. Now, all of it breaks my heart. But the press counterfeit pills, truly, they're being sold on Snapchat and social media to elementary age, middle school age, high school, on up. And these kids, I'm going to call them kids because they are kids, think they're buying Percocet or a Roxy or something. And they're almost being groomed by known dealers on Snapchat. Let's just say Snapchat. And they are sold or given something, and all of a sudden they're dying. I mean, it's crazy in this country. Do you know of any other scenario that I'm forgetting or not mentioning?
That's actually a very good synopsis that you said. We have the severely addicted substance use disorder patient who intended on fentanyl, has high tolerance, injects fentanyl, smokes it, or snorts it. They have a large physical dependence. They get very sick if they don't take it. That would be the first level you described. And also, heroin simply isn't available anymore. Most of the patients I admit here in South Florida don't test positive for heroin or opiate. They test positive for fentanyl. The second level would, as you said, maybe they just intended to party some, but they've used enough opiates. They may have withdrawal, and they thought they were getting a Percocet or a Xanax or some pill that came from a pharmacy, but it's not. And then even as you said, the scariest level to me is the bachelorette party or the bachelor party where maybe they took a Xanax when they were in college or something. And at celebrating this weekend, they thought they were going to do some cocaine and take a Xanax, and they have no tolerance for this very powerful opiate, and they die on the spot.
So, with all that being said, do you feel that these deaths should be described as overdoses or poisoning?
That's excellent to even bring it up in that light. I had just read today that this should be looked at as a national security issue. No different than someone were attacking our country with chemical warfare.
Exactly. It does seem to be that way, chemical warfare. And it's like you said, I think the numbers, I believe last year in 2020 were 94,000. And I don't know how many of that is illicit fentanyl. I've read so many different things, 50, 60, 70, 80%. But I think the numbers are a lot higher. And I think in 2021, they're going to be a lot higher. I don't know how accurate the information is, but I just feel like it's going to escalate. and keep escalating. Is that how you think or feel?
Yes, and I think it has to be approached as any national security problem would. I think back on how we've approached terrorism. So we both did more screening at the sites. We've done more screening at the borders. I think addiction particularly the fentanyl problem, the opioid crisis, has to be addressed the same way. We need to enhance our abilities so it doesn't get into the country, but at the same time, don't overlook its marketplace. These patients who have a vulnerable dopamine reward system, no matter where they fit in that spectrum of people who are going to use them, we just described all those three scenarios need treatment. And we've
Yes.
got to make that treatment available and offer, I won't say necessarily pay these people to do it, but offer a rewarding lifestyle that they can see. They need some incentive for it.
Yes, I see that. And the journey with addiction and the stigma attached to it, a lot of people cannot get jobs. So yeah, they do need to be rewarded. They need some incentive to work towards to better their life, to better themselves, not necessarily all the punishment or I think you know what I'm saying because you
I
live this
do, and
yourself. You live this yourself.
yeah, and I advocate for a term called contingency management. Is that all of these fruits of my recovery don't continue if I don't have negative drug screen tests. So, instead of that, oh my God, you know what, my mom's driving me crazy. She's making me give urine specimens 4 times a year next year or something. But those come with a reward that, yeah, not only that, but your car insurance is cheaper, your college tuition's cheaper, but all of the fruits that go with then mind altering substance free become more readily apparent to them. And that the
Hmm.
testing is not looked at as a penalty, which is the way it's looked at now.
Yes, it is. Um, well, you have come a long way. I don't want to give too much about your book because I really want people to buy it. I bought mine on Amazon. I'm going to put a plug in there about Amazon. But I really learned so much from your book and it really opened my eyes. I loved reading about your firsthand experience with this yourself and what was involved, and also your colleague, Dr. Hunt. Is that correct?
Yes,
That's Jason Hunt.
yes.
And you both were medical doctors and you both suffered with this for years and it changed your life. And you had to do some really soul searching and hard work to get your life back. You both lost your medical licenses over this. Is that correct?
Yes, it is.
And then you worked and did what you had to do and got it back. So, my goodness, God bless you both. I mean, I used to tell my son, you're like the strongest person I know. Because I saw his battle, every day with this. And this is something that you live with the rest of your life. And it is a battle. Is that correct? Is that
Well, initially, yes, it is, but it actually, with appropriate and proper care and compliance of the patient, most of us believe this day the disease goes into remission. I look at it no different than I use the example of a breast cancer patient quite often. I have a breast cancer patient. They have a lumpectomy, radiation, chemotherapy, and 15 years later, they're good. Now, that doesn't mean they stop doing mammograms. That doesn't mean they stop doing breast exams. That doesn't mean they start smoking cigarettes. That doesn't mean they start drinking alcohol. They start going to the tanning bed. Anything that would be increased risk factor for cancer. So the same now. I'm sure my disease is in remission today, but I go to a wedding. I make plans. I don't drink champagne. If I go to the sports bar for buffalo wings, I have a Diet Coke. I have a lemonade. Mexican restaurant. It's frozen lemonade, not a margarita. Uh, and that didn't happen by accident. That happened by good scientific medical care, and importantly, compliance with treatment. I have to have that from patients. So that's why I need the families involved, because it's not them nagging them, it's just helping me ensure compliance.
Exactly. Right. Nagging doesn't help anything.
No,
um,
but help it. They'll call that their sober support network. Their sober support network, would be involved in. Well, you're going out with these 10 guys that you went to high school with, and all you all ever did was drink and smoke pot. What do you think you're going to do with those guys tonight? What would you possibly have in common with them? And if you say, well, I do have to meet them, etc., then I'm going to take a sober friend. I'm going to have extra accountability, and even say, you know what, you can pee in this cup when you get home too. And if they
so
say
you're
no to that, that's a problem.
so you're more aware, definitely, and more conscious about all of this. And that's what it takes, right?
Education is the pathway out of this one.
Yes, sir. I believe
Because
education is power.
what seems to be a voluntary disease is actually not, because of all the social pressures. I had that phrase in my book that in this country, alcohol is not just socially acceptable, it's socially expected. That has
You're
to
right.
change. That has to
You're right.
change.
Yeah, it
People,
does have to change.
teens get peer pressure bullied into alcohol and cannabis.
Most definitely. Peer pressure is a major thing. And nowadays it's pill parties. They're pressured
Certainly.
into taking pills. It's just not, I mean, it used to be just smoking cigarettes or drinking a couple beers. That has changed a long time ago.
Exactly.
Peer pressure has a lot to do with it. Yes, sir. Well, gosh, Charles, I could talk to you all night. And you're just a wealth of information. And I just want to thank you for being so transparent with your own story about your journey. And I want you to know that you are so loved and appreciated in doing so, and in also helping to make a difference with others with their continued battle with this. And if you or my audience, if you or a loved one is struggling with addiction, you'll find help in Dr. Smith and Dr. Hunt's book. And it is called, again, Understanding Addiction, Know Science, which is KNOW, and to Know Stigma. Let's end the stigma. It's up to us as individuals to end the stigma in this country. And when one understands the science behind addiction, one can begin to move forward. Because beyond stigma, there's always hope. There still lies hope. And thank you, Charles. I really do appreciate it. I
Thank
hope
you.
we can possibly interview sometime again in the future. Okay.
Okay. Certainly.
Okay. It's been a pleasure. Thank you.
Uh-huh.
Take care.
Uh-huh.
Bye. Thank you. To our listeners, thank you for tuning in. Please subscribe to this weekly podcast. Visit our website, which is linked below in the description. On the website, click on the social media icons and feel free to share this podcast with others. And also, please leave your reviews and ask questions that you would like for me to ask our guest for our next episode, dealing with the fatal facts of fentanyl. Enjoy your week. Many blessings.